everyone today, which is known as World Cancer Day. And today this webinar is organized for Educate, Empower, Eliminate Women's Cancer, organized by FOGSI No to Violence Against Women's Committee and FOGSI Gynecological Oncology Committee in collaboration with Tamil Nadu Federation of Obstetric and Gynecologists and the Obstetric and Gynecological Society of Southern India. To kickstart the meeting, I would like to introduce the organizer, Dr. Jairani Kamaraj ma'am. Ma'am needs no introduction, but I'm honored and privileged to share a few words about Dr. Jairani ma'am. Ma'am is a senior consultant of reproductive medicine, director of Akash Fertility Center and Hospital. Ma'am holds various positions in various societies, namely Joint Secretary in TNFOG. Ma'am was a past president of FOGSI. Ma'am is the current vice president of TAPISA, and ma'am is a South Zone coordinator of FOGSI No to War Committee, associate secretary of World.
Sana, that is enough, Sana.
And ma'am have various.
Sana, it's enough, Sana.
Handing over the session to ma'am. Please take over, ma'am.
Thank you, Sana. Respected and honorable President Dr. Sunita Madam, esteemed speakers and guests, and also my respected colleagues and my friends and all my senior mentors. It's my great privilege and honor to welcome you all for this webinar, which is a Cancer Day awareness program, which has been initiated by our esteemed President, Dr. Sunita Madam, to make this program a very important one on this Cancer Day to create an awareness on the women's health. And we are here to come together to touch the cause, which is a very important cause for the women's health. And at the outset, I would like to extend my deepest gratitude to my Honorable President of FOGSI, Dr. Sunita Madam, whose unwavering dedication to women's empowerment, healthcare, and the cancer care, which is a very important one, which inspire us and guide us. The very word I asked her, immediately she accepted. Thank you so much, Madam, for being with us. Your presence here today is a powerful reminder of the collective efforts you are doing to advance healthcare, which involves so many things for the cancer care of the women of India. And really, we are all very proud to have you here, and it's a very honor and privilege. And we all know we are celebrating the Cancer Day on 4th. And to continue this, we know the theme of this year. And to cover this, to create an awareness and to have the advancements in the latest trends in the treatment of the women's health care, gynec-oncology, we have here many esteemed and the very knowledgeable faculties here. I welcome all the knowledgeable faculties here, Dr. Bose sir, Dr. Ramani Devi madam, Dr. Anita and Dr. Raja sir, and all our Federation President, Ramani madam, Sampath, and all the committee chairpersons who are very much dynamically working with madam, Dr. Kiran, Dr. Sarita madam, all here. I'm very honored and happy to have you all here. And it is a real great pleasure to have everyone here. And I welcome you one and all for this webinar. Let's start the webinar with a Tamil Thai Varthu, which we always give as a prayer to the Tamil goddess. Can I have the... So we'll start with the traditional lighting of Kuttuvalakku, where we always think the knowledge of light can be brought with the lightning of this Kuttuvalakku. That stands for the knowledge. Please start, Sina. It's not playing. Priya, we'll move to the inauguration, Priya. Yeah. With a great pleasure, honor, and a very honored way, I have the greatest pleasure to introduce our dynamic and the ever smiling and the very gracious and the women of grandeur with so much of strength and knowledge in her face in everything what she does. Our President FOGSI, Dr. Sunita Madam here, who is the President FOGSI 2025 and who has been the founder president of Society of Ovarian Rejuvenation and who is the president of Pune OBGYN Society between 21-22 and the chairperson of the founder honor secretary of ISAR and second vice president of ISAR and the president of IAG between 2019 and 20, vice president Weststone between 2015 and 2017, and who is the elected board member of ISG 2013 and 2017, and who is a receiver of so many awards like IVF Icon Award in 2022 by the Economic Times, and she has got the Pride of FOGSI Award in 2022, and she has got the Bharat Gaurav Puraskar Award.
Let's move on. This is
And,
all our
no
team.
words, no, madam. We have to say about you because it's very important for us to say about you because it is a forum of all the gynecologists,
Can we
oncologists here.
stop
They should
screen
know about you,
sharing?
ma'am.
Yeah, just
And-
stop screen sharing. Na?
Yeah,
It's
please.
lovely to see all of my friends over here. So thank you so much. Thank you, dear. Thank you for having me over here. This is yesterday we celebrated by doing many physical CMEs across the country on World Cancer Day, and we released our Do Tike Jindagi Ke. It was released or launched in a very big way in Pune and Mumbai. In Pune, whoever the FOGSI team is, Dr. Parag Biniwale was here with us. And we had our committee chairpersons, our joint secretary Ashwini, Ashish Kale, Chaitanya Ganpule, Nilesh Balkaude, all Vaishali Chavan, all my team members were here. While in Mumbai, Swarna Khadilkar, Komal Chavan, Priya, these all people joined together. But I saw so many committee chairpersons have done amazing work. Whichever city they belong to, they were there. I think Dr. Sarita Kumari has done a very good job as a oncology committee chairperson, and she communicated with all the presidents and asked and requested to conduct as much as the awareness program about cervical cancer vaccination. I'm so happy, Jairani, you have taken this initiative and you have taken this webinar so that we can discuss about it and we can share our experience, our vision, and I'm sure everyone over here will carry home and will bring the awareness. See, it's a very unfortunate story that it is second most common cause of death due to cancer in women. And unfortunately, the only cancer against which vaccine is available. The uptake of vaccine is less than 2%. I don't know why. So, Do Tike Jindagi Ke, naturally, because it's a Do Tike, it is my program for 9 to 14 age group. And we have now already American Cancer Society giving us 50,000 US dollar, more precisely, 50,061 dollars. So we are working towards, Dr. Rishikesh Pai has done a wonderful job. And he has made the awareness with 10,000 gynecologists and created 100 TOTs. it's always wise to carry forward the work of that president. So I got 100 TOTs of a gynecologist with me. So what I did is I asked them to join, and we are now going to train 50,000 IMA doctors. So I need to thank President Dr. Rushikesh Pai, who has done a work along with Priya and gave me 100 gynecologist TOTs ready to create the awareness, to create the program, to create 50,000 IMA TOTs. It became so simple for me to do this program, and we collaborated with IMA, Dr. Bhanushali from Hyderabad, who is the IMA president. He joined us, and we are working on this. There are so many things we are doing for cervical cancer awareness or elimination of cervical cancer. You all are aware that 2020 WHO has said 90, 70, 90. 90% of the women should do the checkup, 70% should be also vaccinated, and 90% who came positive should undergo treatment. Unfortunately, even if you see 90, 70, 90 में, between 0.5 to 3% is an uptake in each section. I don't know why this is happening. We gynecologists are eager. So where are we lagging? So we are doing with Japaigo one big project, and we are launching it as a pilot study with Varanasi. The two important aspects of choosing Varanasi as a for the project: one, it is the Prime Minister's constituency, so probably it will attract the central attention, and maybe the government will work hard to make this project run. Secondly, in Varanasi, there is a Tata Cancer Institute. So those who come positive will get the treatment over there, and our job will be easy. So we are launching this Nirmal Banaras Abhiyan. So I want you all to bless us to take these projects, to work on these projects. It's a completely only restricted to Varanasi, but it's going to make some fruitful, and probably we are getting the donors also for the same. So I'm thankful I have collaborated with Japaigo, because Japaigo is already working with the Tata Cancer. So we have taken Japaigo, and probably we'll get one very good donor, and we will make it not only just in Varanasi, but maybe 3 to 4 states will be able to adopt. So I request you all to join all the FOGSI projects, not only this, but all the FOGSI projects. And thank you once more. I can see Sneha, Vinita, who will be going for the elections, and I wish them all the best. They are hardworking, whether on chair or off chair. They have always worked for FOGSI, and I think FOGSI also needs dynamic people. Thank you so much.
Thank you, madam. Thank you, madam. Thank you so much, ma'am. As you rightly pointed out, this year, the Cancer Day theme is United by Unique, which says about all the promote the people-centered care and all the things to be united, as you rightly said, that we all should join, and we will definitely be honored to join with you all.
Just, Jai Rani, my very humble request, since you and Sampath are from Chennai, Do TK Jindagi ke program, do as much as you can in an adolescent age group, in the colleges, and see to it that you promote. I know it's very expensive to get the vaccines, but promote or join the NGOs like Rotary and all, who may get at subsidized rate from MSD, because MSD International is giving very low rate to the Rotary clubs, not to FOGSI, but to the Rotary clubs.
Yes, ma'am. Yes, ma'am. Rotary Club, I have been contacting the Rotary Club. They've accepted to pay for 750, madam. So we are just planning to have a big way of immunization in the colleges, ma'am. Definitely, we will take up your way forward to work for it.
It's very important, whatever work you do, please document it and send it to us.
Sure.
Thank you.
Thank you so much, ma'am. Thank you for your lovely time, and thank you for your energetic inspiration, which is really a very great inspiration for all the 45,000 gynecologists all over our country. Thank you for sparing your precious time, and thank you, madam. Over to Aruna. Aruna is here.
I think she has some issues connection, Jerani. Carry on.
Okay. So I'll be very happy to introduce the guest of honor, Madam Dr. Ramani Devi, who is a very dynamic person from Tamil Nadu, who is our mentor and a very good guidance of all this active work. What we are doing in Federation is with her and our dynamic Sampath. Both of them are like a pillars for the TNFOG to build it across from the basement to a multi-storied one. And Madam is a very sweet person to guide us in everything. And Madam is the present TNFOG President 2024. And she's the,
stop it. Already we are delayed. We can
yes,
go ahead.
Over to you, ma'am, for your words of wisdom. But definitely you need a lot of introduction, and you need a very much introduction with your friend, Dr. Bose, sir.
It's okay.
To know about you still more in a better way. Thank you, ma'am. Thank you.
Respected President FOGSI, Dr. Sunita Tandulwarkar, Vice President Dr. Varsha Baste, and all the chairpersons who are there, Dr. Kiranmayi, Dr. Sarita, and Secretary of Secretary of TNFOG, Dr. Sampath Kumari, and the conveners, Dr. Aruna Suman Jairani, and President and Secretary of FOGSI, and all the chairpersons and the speakers for today. I think it is a very, very important webinar today because in India alone, we have out of 1 lakh women, 105 women die of malignancy somewhere. And the commonest malignancy we know is the breast, which is followed by cervical, and then the ovarian and uterus and the other malignancies. And you see, it was really surprising. The incidence of malignancy in women is much higher than men in Tamil Nadu. So that means we have to have, as a forum of gynecologists, we need to give more importance for detection, prevention, early detection, and proper management of any type of cancer, what we are seeing in the women. And today, we have 2 great speakers and a panel discussion by the great moderator, Dr. Anita. And the speaker is Dr. Jagdish Chandra Bose, and who's my classmate, and you should see him operating. Very, very excellent surgeon he is. And I had the opportunity of assisting him for many of the oncosurgeons. And I'm really happy that he's been one of the speakers. And I also have, we have Dr. Raja and others, and all the experts and panelists. I think, Jairani, you have done an excellent job by organizing, putting everybody together in this single platform. And I don't want to in between this speakers and the talk. I think we are running behind schedule. We can go ahead with the speakers. And I thank Dr. Jairani for inviting me for this important meeting.
Thank you, ma'am. Thank you so much, ma'am. Thank you so
much. And all the best for all the people who are going to contest for the election.
Thank you, ma'am. Thank you so much, ma'am. Kiran, a few words from you.
No, we are delayed, Jaya. I think we will not stand.
All right. So we'll move on to the academic session. Thank you so much for the chief guest and the guest of honor for sparing your time and blessing us. We'll move to the academics. Priya, can I have these chairpersons for the first session? We have Dr. Neeru Thakral. Madam is the Secretary General of GOGS between 2024 and 26. Madam is the fellow in the reproductive endocrinology and ART from Germany. She has got so many awards. She was the Vice President of Haryana Endoscopy Society, past Secretary of IFS Haryana Chapter 2018 and 21. And she's the National Coordinator of IFS Young Turks Journal Club. And she's a Principal School of Embryology of ART. And her special interest, we know nothing than ART and reproductive endocrinology. Madam is very dynamic in all her work in endoscopy and ART. We welcome you, ma'am. And we have Dr. Aarti Kaushal, who is the consultant OBGYN from, she's from Ahmedabad. Madam, she did her MD from Ahmedabad. Her She's experienced more than 20 years, and she has delivered more than 10,000 healthy babies. And her prime interest is OBGYN, caring for expectant mothers and delivering healthy babies. We are very happy to have you, Madam Aarti. We welcome the chairperson, Dr. Jagdish Singh, sir, who is a senior medical officer from Malarkota, and he has done his affiliation as a honorary secretary of Faridot OBGYN Society, and her vice president of IMA Ludhiana, vice president of All India Federation of Government Doctors Association, and the chief advisor, Specialist Doctor Association of Punjab. Sir has AACOG faculty of more than 15 years with a vast advanced knowledge and experience, and he has done a Master of Trainers of program of GOA sponsored RCH program, and he has been the administrative officer cum consultant for PCPNDT and MTP Act, monitoring various health departments in Punjab. And it was very nice to have you, sir. We welcome all the chairpersons, and a very special welcome to Dr. Sangeeta, who is a professor and head of the Department of SGRD Medical College, Amritsar. And Madam has 23 years of experience, who is the president of the Amritsar Menopausal Society. And she has done a lot of literacy and awareness program. And she has achieved a lot of more than 40 publications to her credentials in national and international journals. And she has been a guide as well as co-guide of many postgraduate theses in OBGYN. And she has so much of program done for the postgraduate students, both in the internal as well as in the external examinations. And her special interest, she has been a trainer in the intrauterine insemination procedures and laparoscopy and hysteroscopy. We welcome all the chairpersons. Over to you, chairpersons, for the introduction of the, Madam is for the next session. Kindly stop sharing. May I request the chairpersons to introduce the speakers? Dr. Jagdish Chandrabose. Over to chairpersons.
Stop sharing.
Kindly put Sir CV. Sir.
Thank you.
Chairpersons, please. Any one of the chairpersons can introduce, sir.
Madam, no problem. I think it's there on the slide. I think you can go ahead. Maybe they're muted.
Yeah.
Hello.
Sir, yes, madam.
Hi, yeah, good evening. This is Dr. Aarti Kaushal from Karnal.
Yes, ma'am. Thank you, ma'am. Welcome, ma'am.
Thank you. It's my pleasure to introduce Dr. J.C. Bose, sir, for the first talk. Dr. J.C. Bose is a MBBS and MS and MCH. He specializes in surgical oncology with 26 years of experience. He's won a gold medal in anatomy. He's a member of several organizations and associations which are related to oncology. Apart from that, he likes to attend seminars and conferences, deliver orations where he gains knowledge about new advancements in the field of surgical oncology. We welcome you, sir. We are pleased to have you with us here today for the first talk.
Aarti, madam, you should see sir's webbing specimen. It will be like a clear anatomy what he will do with the dissections, and it will be really very much amazing and fortunate for most of the postgraduates who operate with him. So such a good, very good surgeon.
Jairani, one more thing is he was the best outgoing student of Tanjavur Medical College. That they have not put in the CV. Best outgoing student, one of the earliest person to do surgical oncology.
Yes, ma'am. Thank you, ma'am. Thank you, ma'am.
Madam, good evening.
Yes, sir.
People, right? My slides are visible, right?
Yes, sir. Yes, sir.
So thank you, madam, the president of FOGSI and the chairpersons of this particular talk, Dr. Jairani, and my classmate and good friend, Dr. Ramani Devi, and all the other dignitaries here, the delegates who have joined, the members of this association. It's indeed a proud privilege for me to be before you. It's one of the very big organizations I know that caters to the demands of women. And I believe when your president addressed, we know that you're doing an immense job in prevention of cervical cancers. So let me start my talk, which is going to be something about the recent advances in ovarian carcinoma. I'm just going to give you a comprehensive overview. It may not be covering all the subjects, but I think it will give you some insight into what the ovarian carcinoma treatment is going to be like. So the outline of my talk is going to be like primary prevention, which is of course the screening. The secondary prevention, which is going to talk about something about early detection, what we have achieved. And then about the tertiary prevention, which is the treatment. Now, when you want to talk about the screening for ovarian cancer, we need to know all these risk factors. We have come a long way in the years to come about what we understood about ovarian cancer. We know that hormones play a role and the genetics is a part of it. And then now we understand that the mucin antibodies, which are initiated by your mastitis and sometimes even fractures, could cause a protective role, the mucin antibodies which are present. Now, this is our learning in the years to come about the etiology of this ovarian cancer. So when you understand the etiology, we know that we can have some screening programs. We can initiate some awareness among women as to what they should do and what they should not, and who are considered as high-risk people and how you should screen them. Now, my next slide talks about what is called as the genetic screening or what is the primary prevention. This, as you would know, is the most important part, but it is very often very difficult to apply. So it talks about two important testing, one about the BRCA testing and the other one about the microsatellite instability, which is found in the Lynch syndrome. So these two are important genetic factors which could make an individual develop an ovarian cancer. So if you could analyze them after a good genetic counseling and go by this chart, you would be able to do some risk reducing surgeries by which you can, of course, prevent the ovarian malignancy. So you know very well that prevention is the best form of cure as the individual doesn't suffer from the disease. So this is one of the best forms of treating an ovarian malignancy. Next comes diagnosis, that is, and evaluation. So what are the advances we have in diagnosis, evaluation, where we can detect the disease early and do a good secondary prevention? We know we have an era of modern imaging, and the technology has helped us to do immense imaging, and that would help us. Then we have an era of molecular, genetic, and precision medicine. So this is an era where we have genetics, precision medicine, which talks so much about early detection. And then we have the most important era of artificial intelligence. Now, these three eras have emerged and they have really revolutionized the early detection of ovarian cancer. We are going to just go through some of them. And you know that early detection in the form of identifying the disease at a very early stage could cause something like a 90% cure rate. And this, of course, is most important because when you diagnose the ovarian cancer at a late stage, our cure rate drops down to something like 30 to 50%. And so we know very well that early detection is the most important part in ovarian cancer diagnosis. Now we have various tests. We've gone through them. We know that we can list them out. Now, what are the recent advances in this? The recent advances, what we see is a FAPI scan, a liquid biopsy, a detection of tumor DNA, and of course, AI enhancement. Now, I'm just going to go through all this because we know that we are routinely going through something like a transvaginal ultrasound, a magnetic resonance imaging, which may be a functional imaging sequences, which could even tell you the tissue characterization of a particular tumor. And then we have the FAPI PET now. The FAPI PET is definitely better than the FDG because it can predict better about the tumor responses and about the diagnosis where it has got a high sensitivity for peritoneal metastasis, better tumor to background ratio so that image interpretation is very good. It is potential for upstaging the disease where you cannot make out by the FDG PET, and it is better taken up by the mucinous tumors, which are often FDG non-avid, and it reduced activity in the kidney, bowel, and bladder, brain, and liver, which makes the other tissues better evaluable. Now, this is just an example of what the FDG shows and what the FAPI shows. You know that the tumor lights up better, and the tissues which are affected also light up better with the FAPI PET. Now, next comes the sentinel node. Do we apply this on ovarian cancer? Yes, we have applied it on ovarian cancer. We know that we have good results where we can reduce the morbidity of our dissection, especially when you need to do a pelvic node dissection or a para-aortic dissection, whether it could be avoided when the sentinel node becomes negative. So a systematic lymphadenectomy can be avoided if you have a good sentinel node, which can be detected by either an ICG or an aneuploid. So we know that we have robotic assisted sentinel node biopsies, which could target the node, pick it out, and make your lymphadenectomy unnecessary, thereby avoiding the morbidity of your lymph nodal dissections. Now, of course, these have to be done in selected centers where you have a good pathologist to analyze and do good sections to find out whether the sentinel node is negative. So we have various trials. Some of them I've listed out here just to tell you that sentinel node will come in ovarian cancer if it is established. And as we know here, the detection days are as high as 87%, and we have a false negative rate of less than 5%. And this can really make a beginning to what is called as a sentinel node biopsy in ovarian malignancy as well. Of course, it is established in endometrial cancer. We know that it can make a big way in ovarian cancer as well. Now, we have biomarkers and we have other molecular agents. Now, the common one is the CA125. We have HE4, where we have the risk of malignancy algorithm, which is the ROMA. And then the recent one is, of course, the liquid biopsy. We know here we are detecting the circulating tumor DNAs, and this can help us to be useful in monitoring the treatment response. And we can really decide when you want to stop the treatment or when you want to restart the treatment. So in this way, the liquid biopsy will help the medical oncologist and the other people, and then it can help the people to choose the surgery. I'm not very sure whether it will be useful in early detection right on this date, but it can definitely guide you in the treatment profile of a ovarian cancer patient. Now, then comes the genetics and the molecular profiling, where we have the BRCA1 and 2 mutations, so which can be made out in the chromosomes 17 and 13, where we can offer prophylactic surgeries for the individual, thereby they don't suffer from these malignancies. The multi-gene panel testing, which is the HRD, can help you decide about the PARP inhibitor therapy, and the next generation sequencing can also help you in finding out targets which can be addressed in some tumors when they become resistant to your chemotherapy. Now, what are the other techniques which we have? We have optical imaging techniques. The current one is the folate receptor target, which could be taken out in these tumors. We have, of course, this prafolacenin, which is an agent which can target the folate receptor in the ovarian cancers. And when they are detected by the infrared imaging, you know that these tumors can be better lighted for the surgeon so that they don't escape the surgeon's vision. We know very well that when a surgeon operates, his vision is limited. He is not able to see all the cells which are lying down in the patient's abdomen. So if your vision is made better by these optical imaging systems, you know that you can definitely do a better job. And that is, of course, by utilization of fluorescence guided imaging or Raman spectroscopy for high resolution tumor visualization. So this will definitely help us do better surgeries and make your R0 resection much more effective for the patient. We have methylation-based test, which can, of course, sometimes made very simple as a home screening test by finding out the epigenetic changes in the body fluids to identify high-risk individuals who have the propensity to develop endometrial or ovarian malignancies, especially the serous variants. Now, where does this artificial intelligence come in? The artificial intelligence can really help you in imaging analysis, where you can have even a histopathological diagnosis or a radiological diagnosis with better accuracy. It can give you a predictive analysis, putting in all the genetic, clinical, and imaging data together and give a personalized risk assessment for an individual. It can help you in deep learning algorithms to improve the differentiation between the benign and the malignant lesions, and thereby give you automation and standardization of your diagnostic procedures, which are often lacking and which do better decisions for an individual patient, especially when you get sometimes discordant cases. Now we come to the most important part, which is the tertiary prevention, where we deal with tumors. We have been seeing these eras, the pre-cisplatin era, where we had a dismal prognosis on an ovarian tumor, which would disseminate into the abdomen. The post-cisplatin era, which produced definitely a better survival in the form of at least 10 to 30% improvement in survival. And then we have an era of CRS, that is the cytoreductive surgery, the HIPEC, the minimally accessed surgeries, where technology helped us visualize these tumors, do a good, better job in these advanced tumors, and thereby claiming an improvement in survival. Now there is a dawn of transplant oncology era, which would definitely go ahead and improve the survival much better in all these patients who become resistant to treatment. So I'm just going to give you a small outlook of all this, and I don't have enough time to go through each of these in a very, very great way. I can say that a recent surgical techniques with minimally invasive techniques, with 3D laparoscopy, robotic assisted surgery, HIPEC intraperitoneal chemotherapy, which is a heated way of giving chemotherapy during the surgery into the abdomen, enhanced recovery after surgery protocols, which are called as ERAS protocols, with multidisciplinary approach to improve recovery, the sentinel node mapping, the fertility sparing surgeries, are all recent surgical techniques which have improved the quality of life and made the better survival for all these ovarian cancer patients. Now, to a little bit elaborate on the minimally invasive techniques, we know we have a 3D laparoscopic systems, ultra HD resolutions with 4K. All these frames tell us that very small tumor deposits in the abdomen can be better delineated and makes possible very fine tissue dissections to be more precise. And what is not seen on your naked eye or by your magnification will be better made out by the near infrared fluorescence, which I was talking to you about when you target the folate receptors, the augmented reality and artificial intelligence assistance, which can guide you do a better surgery, and advanced depth perception technologies. Now, these technologies definitely are going to improve our surgical outcomes, which give us enhanced depth perception, better tumor margins in cytoreductive surgeries, less strain for the surgeon, improved suturing and dissection, and better ergonomics. Now, we know that cytoreductive surgery has come a big way in especially a stage 3 ovarian cancer to achieve what is called as a complete cytoreduction with an R0, no residual tumor, which happens to be the strongest predictor of survival. Now, how are we going to achieve it is a matter of controversy or a difficult situation. It depends upon the surgical expertise. the way the surgeon works. It is definitely possible in high volume centers, but how are we going to implement it in a low volume center with a surgeon with less experience? It is yet to be known. Now, these technological advancements like robotic surgery, next generation robotic platforms, haptic feedback with tactile precision for tumor dissection are coming up, and we know that they will take over most of the surgical dissections which are done now in an open way. Now, the features of clinical advantage is greater precision, enhanced 3D, and then smaller incisions, shorter hospital stay, and lower surgical morbidity when you use them effectively and in a proper way. Now, these are some of the pictures where you know that you can do a good cytoreductive surgery, removing the tumor all over the abdomen with a good exposure and a good knowledge of anatomical dissections. We have various trials to support this. We know that sentinel node biopsy is possible with low morbidity with a LION trial, and we have recommendations for HIPEC, and we have the desktop trial telling us that in a platinum sensitivity recurrence, a second look cytoreduction also pays a great way. And robotic assisted surgeries are being increasingly used, and they are considered non-inferior to even an open surgery in a selected patient. Now, the intraperitoneal chemotherapy, which is there to stay, tells us that it has a better tumor kill when it is exposed directly onto the peritoneum, and that can be delivered by normothermic method, putting in a port and delivering a chemotherapy. It can be bidirectional, which may be IV and IP, or it may be given with heat using which may be a closed method, or it may be an open method. And you know that heat improves the cell kill and makes the chemotherapy penetrate better to get better results, especially in a patient who has got a BRCA positivity. So we know that we have come a long way. We have developed organoids which can help you decide who is going to benefit out of this HIPEC therapies as well. So the advances in technique has made pressurized intraperitoneal chemotherapy possible, where you improve the depth of penetration of the chemotherapeutic agents from what is delivered by the HIPEC to pressurized intraperitoneal delivery in the form of an aerosol, where you know you can achieve better results in an individual case. We are not sure whether this will become a standard of cure, but it is a good palliation in most of these people, and whether it can make an individual patient fit enough for a cytoreductive surgery, it is yet to be explored. So we know that a combination of PIPEC with HIPEC for better drug absorption is possible. Personalized drug selection based on molecular profiling is a mandate. Nanoparticle-based intraperitoneal drug delivery can improve your results. AI-driven predicted models can assist you in case selection or patient selection, which is, of course, a mandate when you do high-end surgeries. So we have the ERAS protocol, where we have decreased complication rates, and we have shorter hospital stays and improved patient satisfaction. But it needs to be implemented with the proper help of a team, which involves both anesthetic and a post-operative care. Now, there are advancements in fertility preservation, and I am not here to talk about it because we have a big team of people here who can talk about all this fertility preservation. I've just put them across. We have medical oncologists to guide us when the ovaries can be blocked, and improved chemotherapeutic delivery can be given with adequate suppression of ovarian function to protect the ovarian function. And molecular profiling and personalized surgical decisions can be helpful in preserving the ovarian tissue. And of course, we know that it's a transplantation era where you can even transplant ovarian tissue. So there are recent advancements in medical treatment I've just listed them out here. We have medical oncologists to talk about this. The standard treatment is platinum-based chemotherapy. Targeted therapies are available with bevacizumab, PARP inhibitors, and other targeted therapies. Monoclonal antibodies, the one which was recently released, targets folate receptor alpha, and the immunotherapy, checkpoint inhibitors, CART therapy are all in the experimental trials, and they would come up in the years to come. Now, the transplantation oncology. The transplant oncology is, of course, developing. We know we have multivisceral transplants in oncology, which has been a beginning. A large portion of the small bowel, large bowel could be transplanted if you think that they cannot be removed effectively by a cytoreductive surgery. So this has made a beginning, and this will definitely revolutionize treatment of mucinous tumors and low-grade ovarian malignancies. What are the pitfalls in the recent advances? We know that still we have situations where inadequate incisions are made and debulking is inadequately done. We have problems of what is called a spot site metastasis. So these could be avoided with proper counseling. So sometimes these make uncomfortable patient counseling. It reduces the prognosis, increases the morbidity and mortality, and the survival and quality of life of these individuals. So the patient choice becomes a mandate. This would call for definitely a multidisciplinary tumor board. We have to create a responsible team who take care of the pre-op diagnosis, understand the biology of the disease, perform an optimal operation, and provide a good pre- and post-op multimodal care. So this is the most important need of the hour, where you require a teamwork in management of all these ovarian malignancies. Now, what should be our target? What should be our strategy? And what should be the example? You take a gynecologist, you need to teach them protocols, proper approaches, and a proper preoperative evaluation. In universities and institutes, we need multidisciplinary boards where discordant cases are discussed and proper decisions are taken. When we have a gynec oncologist, we can, of course, have a precision approach where they decide based on the pre-op decision or frozen section. The future, of course, is genetic molecular approach, where we need to do even the genetics before we intervene on a particular patient. Now, what is the need of the hour is personalizing the treatment. We don't have Angelinas in our place. We have Angelis. So we need to personalize treatment care. We can't apply what is there for Angelina to Angela because we have social settings, we have financial settings to take care. So please try to personalize your treatment and please try to talk with your patient, communicate before taking decisions. In conclusion, what I want to say is the clinical medicine is being buried by technology. So we should embrace technology with caution. The clinical medicine still remains. The path of evidence-based medicine has a lot of potholes, bias, morphed statistics. So you need to walk on a well-tailored path. Personalized precision genomic medicine is sometimes oversold. So we need to be cautious about that as well. And what is the need of the hour is patient-centric humanization, where we need to use a proper clinical judgment and personalize the treatment care for an individual patient. So thank you very much for your listening. I would stop sharing. Have I stopped sharing? Right. Thank you.
Over to chairpersons.
Thank you, sir, for that. Yes. Thank you so much, sir, for that comprehensive and meaningful talk on recent advances in ovarian tumor management. We all understand that it is difficult to take such an elaborate topic in such a short span of time. but sir has quickly and very nicely covered all the aspects, including the screening, diagnosis, and evaluations. So thank you so much, sir. Thank you.
So I would like to introduce Dr. Aruna. Can I have Aruna's CV? So Aruna, can you introduce?
Yeah. Thank you, Dr. Jairani, for the opportunity. Thank you, Dr. Kiran. I would like to thank Ramani Madam, TNF FOGSI President, Sampath Kumari Ma'am, Secretary, and Jairani Kamra. Special thanks to you for this great opportunity today. And I would like to introduce our chairperson session. May I have the CVs of next chairpersons?
Sir, Raja sir, can you just stop screening for a minute so that we can put the chairperson CV, sir?
Yes.
Okay.
Thank you, sir.
Dr. Jagjit Singh sir's CV, please.
Priya or Priya, can I have CV of sir?
Dr. Jagjit Singh sir.
Yeah, you can introduce madam.
Okay.
Yeah.
Okay. I welcome Professor Dr. Madhu Nagpal, Madam, who is a ex-professor, head of the department GMC Amritsar and SGRD IMS and R Amritsar. And she did her post-graduation in June 1981, approximately 42 years of academic teaching experience in OB/GYN. Her interests are medical teaching, practical obstetrics, contraception. She's a regional faculty for certificate courses on GDM, contraception, with PHFI, published over 105 papers. And I welcome you, ma'am, today for the second session. Can I have the next CV? Yeah. Dr. Manu Singla, currently doing private practice in Singla Hospital for 20 years, life member of FOGSI, IMS, SFM, and IMA, presently Secretary of Logs and member of FOGSI MTP Committee. Her areas of interest is ultrasound and high-risk pregnancy. I welcome you, Dr. Manu Singla. And yes, Dr. Jagjit Singh sir, he is a former professor, HOD Department of Obstetrics Gynecology, Maharaja Agrasen Medical College, Agroha. His professional experience is more than 24 papers published or presented at national and international levels, contributed various chapters to FOGSI publications, conducted various CME and workshops in infertility and endoscopic surgery, clinical experience 1998 till date. His consultant, Army Medical Corps, Professor MAMC Agroha. I welcome you, sir, to please chair the session and take the program forwards. Can I have the CV of the speaker, please? We have one more chairperson.
Dear chairpersons, can you introduce the speaker?
Respected chairpersons, please introduce the speaker. Okay.
Shall I take the privilege of introducing Dr. G. Rasa?
Yes, Dr. Vinita Singh. Yes, please do that.
So thank you so much. So here's the next speaker as Dr. G. Rasa. And regarding his personal details, he is...
Madam, Manu Madam is there. Madam, Dr. Manu Madam? I think Madam is there.
Yes.
Okay, Vinita, can you go ahead? Vinita.
Okay. So he is Associate Professor in Department of Medical Oncology, Government Kilpauk Medical College, GRH, Chennai. And his degree regarding, he has done, lots of degree he has got, and his certified course from Jefferson University, USA, and certified course from Harvard University, USA. So over to speaker Dr. G. Raja to give your talk.
Thank you very much for a nice introduction, madam. I sincerely thank for
Sir, can you
FOGSI.
put, sorry, sir, can you put in a slideshow mode, sir? It is in a. You have to click the slideshow up. Yes. So you click the slideshow there up, sir, or in the bottom?
Yeah.
Yes, sir. Yes,
Thank you very much, madam, for a nice introduction. And thank my professor, Kalichalvi madam, for giving this opportunity to talk in front of the FOGSI members. So happy to have this session. I am going to talk on screening and early detection of gynecological cancers. I'm not at all going to talk about management, only the screening and early detections. So the important three gynecological cancers are cervical, endometrium, and ovarian cancer. The first, I'm going to deal is cervical cancer. I'm going to talk on these subjects: introduction, risk factors, and risk stratification for screening, and methodology and guidelines for screening and early detection strategies. So this is the fourth most common cancer and fourth leading cause of death in women in 2020 worldwide. And India also, it's the second most common cancer among women and the second leading cause of cancer deaths, estimated deaths during 2020. This makes India the country with the highest number of new cases of cervical cancer and highest number of deaths due to cervical cancer, surpassing China, which was leading in incidence of cervical cancer until 2018. What causes cervical cancer? We know the cervical cancer is caused by the infection called HPV, human papillomavirus. Approximately 15 to 20 high-risk types are associated with the cancer, and 10 to 15 low-risk types are there associated with genital warts and other benign lesions. Most of the time, HPV infection disappears without treatment, but sometimes it persists and may cause cancer in the future. So HPV 16 and 18 is the high-risk HPV type, which causes cervical cancer, more than 75% of cervical cancer, and more than 50% of vaginal and vulvar cancer because of HPV 16 and 18. The HPV 6 and 11 are non-cancerous causing types, which are responsible for the 90% of anogenital warts. So important two types are 16 and 18. The other important types are 31, 33, 35, 45, 52, and 58. In India, 82.7% of invasive cervical cancer is related to 16 and 18. And in India, about 5% of women in general population are estimated to harbor these viruses at a given point of time. HPV types 6 and 11 are responsible for anogenital wart. The other risk factors are young age at first sexual intercourse, great number of lifetime and recent sex partners, male partner sexual history, and in addition to sexual behavior, other potential risk factors like smoking, oral contraceptive use, and nutritional factor. HPV may be transmitted sexually or non-sexually. The important signs: early cervical cancer usually has no signs, which is why the screen is so important. The signs are vaginal spotting or bleeding after sexual intercourse, or intermenstrual bleed, or after menopause also. Foul-smelling discharge that does not go away even with the treatment. We need to risk stratify the people. We know the high-risk individual, then all others are average risk individual. Who are all the high-risk individual? Those who are having very aggressive HPV type, particularly HPV 16 or 18, and smoking history, or having a weakened immune system, or being immunocompromised, or being infected with HIV, or taking medicines that suppress your immune system after organ transplant or autoimmune disease, or to treat cancer. These are all some of the immunosuppressive agents you can have in your list, so that if there are any patients who are taking this type of drugs, you can screen them for the cervical cancer, because immunocompromised state may bring the cancer, cervical cancer. What's the goal of WHO by 2030 is to eliminate cervical cancer, a public health problem. We need 90% of girls HPV vaccinated by age of 15. 90% of women identified with cervical cancer should receive treatment, and 70% of women screened by 35 years of age and aging by 45 also, up to age 45. Cervical cancer screening, the importance of cervical cancer screening is overemphasized because diagnosis at the early stage is the key to achieving complete cure. So, important precancerous lesions, cervical intraepithelial neoplasia, that could lead to cervical cancer. It is graded into two types. One is low-grade squamous intraepithelial lesion, also called CAN1, or high-grade squamous intraepithelial lesion, HSIL, or either we can call it a CAN2 or CAN3. A patient with lesions diagnosed and treated for CAN3 is at significantly high hazardous for persistent and recurrence than a patient with a lesion that are diagnosed with CAN2. Early stage cancer, cervical cancer is amenable to treatment, resulting in 95% disease-free survival and 98% overall survival at 10 years. So screening is very much important to improve the survival. There are three recommended options for cervical screening in individuals aged 25 to 65 years. One is primary high-risk HPV testing every 5 years, or cervical cytology alone every 3 years, or co-testing with combination of cytology and high-risk HPV testing every 5 years. These important three recommended options. If the high-risk HPV testing is not available, cervical cytology alone every 3 years can be done. The methodology for this cervical screening, one is pap smear or liquid-based cytology, colposcopy with acetic acid test, biopsy, or HPV DNA test. Pap smear test, this is the gold standard test in which we can reduce the annual mortal rate from cervical cancer by 2.6%. One of the most reliable screening method for spotting cervical cancer at the early stage. Pap smear sensitivity is 70% for squamous intraepithelial lesion or aggressive tumor detection. The limitation is its low sensitivity, 70% only. A meta-analysis showed a pooled sensitivity of 61.1% in detecting CAN2 plus lesion. But when after introducing the HPV DNA test, the sensitivity increased up to 94.1% in detecting CAN2 plus lesion. So combining pap test and HPV DNA test will increase the sensitivity of the screening. Next one is cytology. Results are more widely reported using Bethesda system. And the threshold for positive cytology is, one is presence of atypical squamous cells of undetermined significance, or the presence of low-grade squamous intraepithelial lesion. So all women with atypical squamous cells cannot rule out high-grade squamous intraepithelial lesion or LCIL or high-grade squamous intraepithelial lesion. The management of option of ASCUS smear or either repeat smear after 6 months or HPV test or direct colposcopy. So these are all the results of pap smear, ASCUS or AGC, LCIL, ASH, HCIL, AAS or cervical cancers. Next one is liquid-based cytology. Offers an improved test specimen collection with low frequency of unsatisfactory smear and shorter time needed for interpretation. It's a first technique advancement in cervical cytology in more than 20 years. For LBC, the cervical cell specimen is washed in vial of liquid transport medium and filtered. And this can be used for HPV testing also and other molecular testing also. This is one of the advantage of liquid-based cytology. However, liquid-based cytology has more or less equivalent sensitivity and specificity as compared to the cytology. Next one is colposcopy. All the screening positive women need to undergo colposcopy, need to be assessed for suitability of treatment by ablative techniques by the following presence. The lesion should be in the squamous columnar junction, type 1 transit zone, lesion occupying less than 75%, lesion not extending to endocervix or vagina. There is no suspicion of invasive or glandular tissue. So we can go for ablative techniques. The positive predictive value of colposcopy is reasonably high in detecting CAN2 or 3, and treatment can be done on the basis of diagnosis, colposcopic diagnosis alone. The important testing is HPV testing. Involves detecting HPV DNA or microRNA of two oncoproteins E6 or E7 in cervical cell samples. HPV testing is most accurate, reproducible, and provide independent cervical screening test. Its sensitivity to detect CAN2 plus lesion exceeds 90% and CAN3 plus exceeds 95%. It's more sensitive but less specific than cytology. This is to be considered. It's less specific than cytology. If available, HPV testing is more suitable test to screen women above age 25 or 30 years, since HPV negative women can be left alone for 7 to 10 years in view of high negative predictive value of this test. A positive test does not discriminate between infection. We know that host will clear many infection, HPV infection, but this aspect explains the limited specificity of HPV DNA test. So it does not show the active infection is present or not. False positive rates for primary HPV testing are higher than cytology, which may put women at risk for increased follow-up testing and procedures such as colposcopy. So these are commercially available clinical HPV tests. HPV screening for cervical cancer in rural area is one of the important study from India. So the conclusion is, in low resource setting, a single round of HPV testing was associated with a significant reduction in the number of advanced cervical cancer and death from cervical cancer. So HPV testing is very, very important. Hereafter, increasing the HPV testing will bring down the disease and death. The efficacy of HPV-based screening in a European randomized controlled trials. The conclusion says that HPV-based screening provides 60 to 70% great protection against invasive cervical carcinoma compared with cytology. Data of large-scale randomized trials support initiation of HPV-based screening from age 30 years and extension of screening every at least 5 years, every 5 years. So how to approach a asymptomatic woman? If the patient is asymptomatic, yes, we can, if the patient have any cervix, we can, if the patient is immunocompetent, we can go for high-risk screening guideline. If no, the patient exposed to diethylstilbestrol or abnormal cervical cancer screening results previously, we can go for a high-risk screening. Otherwise, we have to go for an average screening risk guidelines only. The recommendations by US Preventive Service Task Force, there is no screening for age less than 21 years. For aged 21 to 29 years, cytology alone for every 3 years. For age 30 to 65 years, cytology alone or FDA-approved primary high-risk HPV testing every 5 years alone, or co-testing. All the three can be done. Well, depends upon the availability. Aged more than 65 years, no screening is recommended. But what the ACS, American Cancer Society, says, the 2020 update shows two major changes. One major change is the recommendation that cervical cancer screening should begin at 25 years, not 30 years. And additionally, primary human papillomavirus HPV testing should be preferred method for screening at the interval of every 5 years. So this is the comparative comparison of recommendations between ACS, ACOG, and US Preventive Service Task Force. For less than 21-year women, not recommended in all the screening guidelines. For 21 to 29, ACS recommends to start screening at 25 years with the primary HPV testing or co-testing or cytology alone. But in ACOG, they allow only cytology alone for every 3 years. For 30 and 65, the same can be done in ACS, but in ACOG, they are allowing to do the high-risk HPV testing or co-testing. For more than 65 years, it is not recommended in all the screening guidelines. So the important age group is 25 years for ACS and 30 to 65 years for ACOG and other group. Who all can be exempted from the screening guidelines? This average risk screening guidelines. So So those who are having HIV positivity are having a weakened immune system, or exposed to diethylstilbestrol, or in the mid-1970s, or recent abnormal cervical testing, or having cervical cancer should be exempted from this type of average cervical screening. So more intensified, frequent testing is required for this group of patients. It cannot be done every year. It can be done every 6 months once. Then what are the other strategies available for cervical cancer screening? Or the nucleic acid amplification test, that is high-risk HPV DNA test or mRNA test. DNA methylation is one of the upcoming tests, and protein biomarkers such as HPV antibodies and oncoprotein. We can see one by one. The other important upcoming test is liquid biopsy. Liquid biopsies allow us to study the presence of tumor material in human fluids. Liquid biopsy include circulating tumor cells, circulating tumor DNA, circulating cell-free RNA, and the circulating extracellular vesicles called exosomes. Identifying these will be used for screening and monitoring the disease during treatment and surveillance for recurrence. It has been highlighted that most promising biomarker is HPV E6, E7 mRNA. The methodology shows 91.6% sensitivity and 98.6% specificity for high-grade cervical lesions. This liquid biopsy can be taken from urine or cervical swab or blood or uterine lavage. In addition to providing accurate information, the presence of specific biomarker molecular features of cancer, liquid biopsy can reflect body response to the chosen treatment regimen and detect early recurrence and identify possible of treatment resistance also. So in addition, they can help to detect early tumors that are not visible by conventional imaging. That's the advantage of liquid biopsy. The detection of HPV E16, E7, E6 and E7 is an expression of oncogenic activity, will identify the presence of disease at the earliest. Another important methodology is DNA methylation test. It's an epigenetic mechanism. Methylation rates correlates with the disease stage in low and high-grade cervical lesion. Increased HPV methylation correlates high risk of severe cervical lesion. So presence of increased HPV methylation will have a severe cervical lesions, high-grade lesions. However, the methylation test is not included in clinical practice so far. It can be expected in near future. So next one is ovarian cancer. Among the epithelial cancer, 70% are high-grade serous carcinoma of ovary is the commonest one. The other types are low-grade serous or endometrioid, mucinous, clear cell. So we have to aim to screen this 70% high-grade serous tumor. What is the rationale for ovarian screening? The chance of cure for stage 1 disease 90%, and for stage 2 disease 70%, and for stage 3 and 4, the cure rate slips to 20% or less. So we need to detect the early stage to get the cure, possibility of cure. In the absence of an effective screening strategy, only 20% of ovarian cancer are diagnosed in the early stage. Most of them will present in the stage 3 or stage 4 only. The risk of ovarian cancer algorithm, ROCA, is one of the screening algorithm. It is a two-stage approach. One is doing CA125 annually, and another one is ultrasonogram abdomen. So if the CA125 is normal, we can repeat the CA125 annually. If it is intermediate, also we can watch and repeat it every 6 weeks, 6 months only. And if it is abnormal, ultrasound should be done and sent for surgery or biopsy. So this is the same ROCA test. If it is normal, we can continue with the 4 monthly surveillance. If it is mildly elevated, we can repeat ROCA test in 6 weeks. Moderately elevated, ROCA plus TVS in 6 weeks. Significantly elevated, we can refer the patient to the gynecologist or oncosurgeon. So screening women at average risk. Most screening strategies have used CA125 and transvaginal ultrasonography as the methodology. Used alone, neither CA125 nor TVS has adequate sensitivity nor specificity. So two-stage approach has improved both specificity and sensitivity. So we cannot use either alone. We have to use both. Each human has to establish her own normal CA125 baseline, individualizing the screening. ROCA is more effective when there is a baseline CA125. If it is not there, ROCA algorithm will not be useful. ROCA is less effective in detecting case in early stage if CA125 already rising on the first test itself and no baseline is available. So better to take a baseline CA125 for all women who are reaching their 40s. So we can have a baseline CA125 in future. It will be useful for them to screen the ovary. Screening women at high risk. Who are the high risk persons? Family history. Having a family history. The risk of disease is known to be 3 times higher if the first degree relative having the ovarian disease, ovarian cancer, and other cancers in the family, like breast gynecology, other gynecological cancer, and colon cancer. So other group is genetic mutations, presence of the genetic mutation, high risk mutation with BRCA1 and 2. They have a high chance of getting ovarian cancer, 40 to 50% in BRCA1 and 15 to 20% in BRCA2 conditions, compared to just 1.3 in general population. They are responsible for 25% of familial relative risk. Next, moderate risk mutations like MLH1, MSH2, MSH6, RAD51C and RAD51D, and BRIP1 accounts for 10% of the relative risk, familial relative risk. The third one is low risk mutations. Single nucleotide polymorphism accounts for 6.4% of familial relative risks for ovarian cancer. But we are concentrating only on BRCA1 and 2. We are not doing other mutation analysis even in the screening or for the treatment purpose, because there is no reliable strategy for early reduction tumors in this group. So we have to do a bilateral salpingo-oophorectomy with hysterectomy to reduce the risk of epithelial ovarian cancer development for these groups. Another option is monitoring them with CA125 level in combination with transvaginal sonogram every 6 months. This is the high risk group recommendation. What is the final recommendation and conclusion for ovarian cancer? The US Preventive Services Task Force recommends against the screening for ovarian cancer in asymptomatic women at average risk. They are allowing for the women with high risk, not for the average risk. American College of Obstetrics and Gynecology, ACOG and SGO also gives the recommendation that there is no strategy for early detection of ovarian cancer because that does not reduces the ovarian cancer mortality. The use of transvaginal ultrasound and tumor marker CA125 or alone or in combination for average risk women have not been proved to reduce mortality. So hence it is not recommending the screening test for average risk women also. The other biomarkers and tests are combination of CA125 and human epididymis 4 protein. Another important biomarker, HE4 is the whey acidic protein, slightly less sensitive to detect early stage ovarian cancer compared to CA125, but it's very much useful in distinguish between the lesion, whether it is malignant or benign. This marker is used in Roma and OVARA test. So it is better used to distinguish whether it's a malignant or benign, and not useful in detecting screening the ovarian cancer. So this is the Roma algorithm, and is one of the oldest method of distinguishing whether it's malignancy or benign. The risk of malignancy index, RMI. What is the recent strategy in the ovary? Here also liquid biopsy is upcoming. Mutation in the T53 gene have been identified in almost all grade serous tumor, and autoantibodies against P53 reported in 20 to 25% cases. So other autoantibodies also are useful in screening or anti-prostaglandin F receptor, and anti-protein tyrosine phosphatase type A receptor, and identifying circulating. So these two important autoantibodies are present in 22 to 32% of ovarian cancer, and it has a 95% of specificity. So liquid biopsy also identifies the circulating tumor cells, circulating tumor DNA, cell-free DNA, RNA, and exomes. So this also in future will be used in screening the ovarian cancer. In endometrial cancer, we know this is the fifth most common malignancy in the woman, mostly adenocarcinoma. Risk factors are old age, early menarche, late menopause, nulliparity, unopposed estrogen. The important one is obesity, PCOS, and hormone replacement therapy. Chronic tamoxifen use, previous pelvic irradiation, and presence of comorbidities, hypertension, diabetes. So obesity has a strong association with the development of endometrial cancer. No other cancers have this much of association. Endometrial cancer will have a very high association with obesity, and if they present with the comorbidities, they will definitely have, mostly will have endometrial cancer. Other risk factors are hormonal treatment of other estrogen-dependent neoplasm, breast and ovary, familial history of endometrial cancer, estrogen-secreting ovarian tumors, and Lynch type 2. The clinical presentation, mostly they are symptomatic. That's why we are able to detect endometrial cancer at the early stage. Less than 5% only asymptomatic. We are able to detect in stage 1 and stage 2 in most of the time. So clinical presentation, we all know this. So the methodology, majority of are diagnosed early when surgery alone may be adequate for cure. History plus physical examination, complete blood count, and transvaginal ultrasound is very, very important, and endometrial biopsy and hysteroscopic and endometrial biopsy are the methodologies. So this is in US and European, 11 million women present with AUB, only 10% is having endometrial cancer. For them, they are doing transvaginal ultrasonography, and they are finding if they have a invasive cancer in endometrial biopsy, they are going for treatment, or if they are normal, they will be under surveillance. Those screening tools, important screening tools are transvaginal ultrasound, measurement of transversal endometrial thickening. So in asymptomatic postmenopausal women, a cutoff of 5 millimeter achieved a sensitivity of 77% and specificity of 85.8%. And the cervicovaginal cytology, urovaginal cytology, endometrial sampling are the other methodologies used for screening the endometrial cancer. Pap smear is not a diagnostic. Abnormal pap smear is the presentation of 1 to 5% of endometrial cancer only. So there is no effective screening test available so far for endometrial cancer. But the endometrial ultrasound thickness more than 5 mm indicates the need for endometrial sampling. The transvaginal ultrasound is the only method which is very useful now for screening the endometrial cancer. Endometrial thickness of more than 5 mm, hyperechogenic endometrium with irregular outline, increased vascularity with low vascular resistance, and intrauterine fluid will be used for screening. So this is the longitudinal view of uterus during transvaginal ultrasound. The thickness more than 5 millimeter is the cutoff. So we can do a curettage on the thickened area and can be sent for cytology. Other new biomarkers are upcoming in for screening the endometrium from blood, circulating mRNA, and from urine, and from uterine fluids and cervicovaginal fluids are there. So the final slide, this is the overview of the screening. The cervical cancer usually screened by cytology or histology or HPV DNA testing. But liquid biopsy has a smaller role in cervical cancer, but it's very much useful in endometrial and ovarian cancer, where we cannot go for cytology or biopsy testing. So in future, liquid biopsy will increase the screening method in endometrial and ovarian cancer, and cervical cancer also will have some usefulness in by the liquid biopsy. So in this context, screening techniques and prevention strategies for gynecological cancer are adequate? No, still we need more biomarkers to screen these type of cancer. And for cervical cancer, effective screening methods exist, but they are underused. For endometrial and ovarian cancer, no effective screening method exists. There is an urgent need to identify novel strategies to detect these gynecological cancer as early as possible to reduce the mortality and improve the quality of care. Thank you.
Over to Chairperson, Madam. Madam, Dr. Manu, Madam.
Thank you, Dr. G. Raja, for such a elaborative and crisp lecture. We have so many take-home messages today. I think early detection and screening of patients for gynecological cancers is very important. Even a simple ultrasound, it can detect so many things at early stage. A simple pap smear, LBC cytology, we need to educate the patients. In our OPD, we need to counsel these patients. As Dr. Raja said, 90% of the girls have to be immunized by the age of 15 so that we can eliminate the CA cervix from this world. Thank you so much.
Thank you.
Thank you, sir. Thank you, Madam. Thank you, Chairperson. Thank you, Chairpersons. Over to Aruna.
Thank you. Thank you, Dr. Jairani. Coming to the third session of this program, I would like to introduce the moderator. Can I have the CV of moderator, please? Yes.
Aruna, we have still more some chairpersons to be introduced. I think we have
okay. They are the experts, right?
Yeah. No,
okay.
Madam is a chairperson. Yeah.
Okay. So I welcome Dr. Manju Sinha, consultant obstetrician, senior consultant with experience of 42 years. She's graduated from Patna Medical College, practicing in Noida 1996 in various hospitals. Her field of interest is high-risk pregnancy, infertility, and all gynecological surgeries. I welcome you, Manju Sinha, madam. And Dr. Gini Gupta. She is President, Ludhiana OB-GYN Society, Consultant Healthline Hospital, Visiting Consultant Cloud9 Hospital, Ludhiana, member of SFM, SMC FOGSI, and AIWF, Manyata Champion and Co-Coordinator for Punjab. And achievements of faculty at various national and state levels. I welcome you, Dr. Gini. And I welcome
Madam, the chairpersons can introduce.
Please introduce the moderator, experts, and the panelists. Let me introduce.
I think Anita, Aruna, you can introduce Anita, madam, and madam can introduce her.
Yeah, okay. The experts and panelists, yes.
Yeah.
It's my privilege to welcome Dr. Anita Thomas, madam, Professor, HOD, Oncology, Christian Medical College, Vellore, Tamil Nadu. Areas of interest: carcinoma endometrium, cancer genetics, GTN, minimally invasive surgery. She has got many accolades on her name. Awards a traveling scholarship, IGCS, to Memorial Sloan Kettering Cancer Center, New York, January 2008. Junior Medical Training Fellowship, Sunnybrook Odette Cancer Center at Princess Margaret Hospital, and traveling scholarship. Welcome. Thank you, Dr. Anita
Thank you,
Thomas, for being there with us today. And please introduce the experts and panelists.
Yeah. So we're very privileged to have our esteemed panelists for today, Dr. Sneha. For the shortage of time, please pardon me. We are all familiar with Dr. Sneha. She's a wonderful person to interact with and has many accolades to her name. And she has won a lot of awards and a very, very enthusiastic person when it comes to education and educating both the public as well as our own co-faculty. So, ma'am, we welcome you on board. Can I have the next slide, please? Sorry, it's hidden there. The
name. Dr. Vinita Singh.
Sorry,
Actually,
ma'am.
the name is not seen. Yes.
So, Dr. Vinita Singh, we welcome you to this panel. Ma'am, thank you for taking part as panelists. Ma'am's, again, accolades are all on the slide for Singh. So I am so sorry I'm rushing through this because we want to give some time for the panel. My other panelist slides are there, or should I just... Dr. Parmita Tiwari is a faculty at our department in gynecology at CFC Vellore, and she will be my co-moderator because she has prepared all the cases and we both will be doing this together. In Department of Obstetrics and Gynecology with special interest in minimally invasive surgeries. She is associate professor and works in CMC Vellore. Dr. Renju. Dr. Renju is based at Dharapuram, and she also is a young achiever and has many accolades to her name. Thank you, Dr. Renju, for being on our panel. Next, Dr. Anbu Khani, my good friend. Thanks, Dr. Anbu, for being there, and I hope I can bank on you for some of the things that we need to discuss in this session. Dr. Priya. Dr. Priya, thank you for accepting to be on this panel, and we hope to have an enjoyable session. So we straight go to our, sorry, Dr. Vanita, you're welcome to our panel, and we hope to hear from you too. We have really a good lineup, ma'am. You've given me a tough job, Professor Sunita Samal from Chennai, and we welcome you all to this session. It was really difficult to plan the questions because I really have a star-studded panel here, so I'll try to do justice. And Mapita is our colleague at CMC Vellore, and she has special interest in gynae too and high-risk pregnancy. With that, we'll go on to share our presentation. So from the last two talks that we heard, we have been hearing about advances in ovarian cancer and advances in can you see us? Can you see the panel?
No, ma'am, we're not able to see the screen, ma'am.
We can't see your screen. Yeah.
Slide we can't see, madam.
Can you share your screen, ma'am? Yeah. Yeah. Now it's fine, ma'am. Put it in the slideshow mode, madam.
Is it okay?
Yeah, you have to put in the slideshow mode, madam.
I just put it, ma'am. Is it showing?
Yeah,
Yes,
but it's not in slideshow.
It's not in slideshow for us.
Full screen. It's okay, no problem. But still okay, ma'am. We are able to read.
Madam?
I think we can.
Ma'am, press F5 if possible, ma'am. F5.
F5. Exit and do F5.
No, madam. You can stay there and do F5.
Ma'am, it's okay, ma'am. We can see that it's only the case scenarios now, ma'am. We can go ahead, ma'am, without wasting time.
Sure. So I've done my justice to endometrial cancer, which is my area of interest. So I'll quickly take you through these cases, and I'll ask Parmita to present the case for you.
So good evening, everyone. To begin with our first case. So this patient, she's a 44-year-old multiparous lady who presented to us with complaint of heavy menstrual
Slides not moving for us.
Ma'am, slides are not moving for us. Can you please stop share and share once again, ma'am?
Yeah, now it is coming.
It's sharing.
Yeah, but it's not moving, ma'am. Why don't you put in the slideshow, ma'am?
Ma'am, you
Yes,
just
yes,
go
from
down
beginning,
and press
from
the-
beginning, from beginning. Yeah, click, ma'am, click.
Just double click on it, madam.
Ma'am, let me, ma'am. Ma'am, please stop share once, ma'am, because you have selected the presentation. Yes, ma'am. Now click on the share.
And this one.
One second, ma'am.
This one.
And click on entire screen and then share, ma'am.
Entire
screen. And share.
Okay.
And share. Share button. Yes,
Yes, ma'am. Yes, ma'am. That's perfect, ma'am.
Thank you, Sana.
Okay, so to begin with our first case, she's a 44-year-old multiparous lady who presented to us with complaint of heavy menstrual bleeding since 1 year, along with some descent mass per vagina, no other comorbidities or any significant family history. She was a bit overweight with a BMI of 26. She had pallor, rest of the vitals normal limits. Her uterus was enlarged to 16-week size, and on local examination, there was some cystocele and rectocele. So with this much information, with the history of heavy menstrual bleeding and pallor and 16-week size uterus, Dr. Ranju, can you guide us regarding like what all further workup or investigation you would like to do for this patient?
Yes, ma'am. I used to work in a government setup earlier, so there is a fear of follow-up. As soon as we see her, we examine her. When we do a per speculum examination, we'll do a pap smear also. Along with it, because she has a 16-week mass with a heavy menstrual bleeding, we'll introduce a pipple and take an endometrial biopsy straight away. Only then we will send her for a vaginal TVS, ma'am, ultrasonography. And her pallor needs to be evaluated as well. Because she has had heavy menstrual bleeding and HB is only around 5.5 or something. So that needs to be evaluated as well.
Yeah. Thank you, Ranju. I think that was a honest answer, which most of us would be doing if we were working in a setup, as you mentioned. But I think most of us in institution would go for the next option of doing probably an ultrasound apart from doing the routine bloods. So we did her routine bloods. She was anemic, and the ultrasound findings was.
So, ma'am, the uterus was enlarged with thickened endometrium, and there was a material wall fibroid of about 9.4 into 6.4 centimeter with normal ovaries. So, Dr. Mapita, can you tell us how you would like to proceed with this patient? What will be your management plan for her?
Dr. Mapita, are you online?
Yeah, she needs to unmute herself.
Yeah. Good evening, ma'am. Basically, her age is 44 and her duration is only 1 year. And it's in heavy menstrual bleeding, and she doesn't have any comorbidities apart from that BMI of 26. So, pap smear we have to do, and TBS, as ma'am said, we have to do. But anyway, 16-week size mass and descent also was there. Better to proceed with her for an hysterectomy. Because of the descent, maybe vaginal hysterectomy, or not, it's a laparoscopic assisted vaginal hysterectomy.
Sneha, madam, any comments on that plan?
I think perimenopausal AUB, unless proved otherwise, we have to think of malignancy, and our investigations are to be to rule out the malignancy. And if at all it is there, then you plan whether you need right from the beginning pre-operative evaluation, complete fitness, and then you decide the route of surgery. So I think she has said it all, but then just going by the size of the uterus, the fibroid, and just having, prolapse, which may be the cause. I mean, the tumor itself pushing the uterus down. So usually you tend to go for vaginal surgery. So that temptation we need to avoid in these cases. And of course, definitely, when you are doing So on priority, basically, you have to rule out malignancy. Once you rule out malignancy, then you have a chance for deciding the route of surgery, whether you can have an option for vaginal hysterectomy with repair. But here in this case, what we can make out, it's mainly the malignancy which is, we are pointing towards, and that is why the route of surgery should be abdominal or maybe the laparoscopy assisted vaginal hysterectomy, which should, take care of both the aspects. And of course,
Yeah.
follow up.
Sure, ma'am. I think we all probably are a bit biased because this is an oncology discussion and we probably know I'm leading you there. But on a routine basis, 16 weeks uterus, fibroid there and anemia, correct. And a lot of us in non-oncology, we would have thought we can, as we follow, I'll tell you what we happened and I will also discuss this at the end as the points that ma'am has put forward.
This patient was optimized, her hemoglobin was built up, and then she was taken for vaginal hysterectomy along with the correction of a prolapse, anterior colporrhaphy, myocardioplasty, and posterior colpoperineorrhaphy was done. Her hospital stay was uneventful. So, Smita ma'am, can you tell about, is there any role of morcellation? Because like this was a 16 to 18 week size uterus, in such a huge uterus, we are doing vaginal hysterectomy. So can we do morcellation? What is your view regarding that?
Good evening, all. Actually, if this was not an oncology meeting, and since the age is only 44 and uterine size is 16 and she has good descent, I would have proceeded with what makes laparoscopy or vaginal hysterectomy feasible in that bigger uterus is morcellation, either mechanical morcellation vaginally or laparoscopy. If we want to stay laparoscopy, we have to do an in-bag morcellation. But the flip part of it is undiagnosed cancers, then we cannot see how much of that, what is the tumor size, how much of the myometrial invasion, and even if when we think of LMS also, we won't have an in toto specimen. That's definitely there. But otherwise, if the endometrial biopsy was normal and duration is lesser, no other red flags, most of us will do morcellation. And all morcellations are in-bag now. There is no without in-bag morcellation or vaginal mechanical morcellation.
If I'm allowed to make only one comment, that age is no bar from any malignancy. If I can share, recently we had a 32-year-old lady having leiomyosarcoma. So the huge tumor and short duration points us towards malignancy, I think. So we have to have a high index of suspicion.
Yes, ma'am. Definitely clinical aspects wise and clinically we have to keep in mind, because once we are doing enough surgeries, there will be cases that will come up like that. So we have to be really alert on duration and rest of the things.
So the guidelines regarding the morcellation, both the obs and gynae guidelines as well as the gynae oncology committees, they advise that we have to counsel the patient. It should be a shared decision, as rightly said by ma'am. We have to judge based upon our clinical findings as well, and then only we have to decide. And it should be within a bag. It should not be without. It should not be an open morcellation. So in this patient, after surgery, the final histopath report came as atypical endometrial hyperplasia with some microscopic foci of moderately differentiated endometrioid adenocarcinoma, grade 2, and the FIGO stage was 1A1. There was no other risk factors involved. So, Dr. Anu ma'am, would you like to comment? Sorry, ma'am. Dr. Anbu ma'am, would you like to comment about the recent staging, FIGO staging for endometrial cancer and the changes that have been incorporated?
And any comments on this diagnosis too?
One of the things is that that I missed is, was it really morcellated in the end, or did we get a whole specimen?
So in this particular
Surgery,
case,
because it wasn't mentioned in the procedure, right? You just mentioned vaginal hysterectomy. So you did morcellate? No.
So it was a very lax uterus. So we are going to go with no morcellation because uterine cirrhosis uninvolved and not
Okay.
say a roomy
Okay,
pelvis
because that was not
to our
mentioned on
credit.
the
For
description of
the
the
point
surgery,
of
just
discussion,
mentioned vaginal hysterectomy.
no
Okay, so the
morcellation, but
question
we
about, got it. We try not to morcellate it as much as possible, but if it does, then we have to assume that that's going to have an impact on further management if this turns out to be malignancy. And European guidelines, most guidelines would upgrade treatment to one level further. So if the patient would have qualified for an observation, she would go in for radiation therapy locally. And if qualifying for radiation, she would be upgraded to chemotherapy in most multidisciplinary units. So that needs to be put forth to patients. So the most important, some of the most important things that endometrial cancer staging has done now, it has shaken up the oncology world. What has happened is the integration of molecular markers. So we need to know that there is a spectrum of molecular classifications that go from good prognosis right up to bad prognosis. I'm sure Anita will be covering some of that later on. But this has now been integrated into staging. There's a lot of controversy about how we read the reports and whether everybody can afford it, but that's how things are now. The other important distinction that the staging now makes is we no longer call it endometrioid, non-endometrioid. We call it less aggressive and more aggressive. So the less aggressive ones are grouped into stage 1. Then depending upon 3 important pathological factors, which is myometrial invasion, lymphovascular space invasion, and then going on to cervix and lymph nodes. And there's a lot of subgroupings now, which is very confusing for most people. So you have to constantly keep looking at the staging anyways to look at it. So this is a program by itself. If you want to look up on the staging, it's a program by itself. But what I would like to leave as a message is that this is really complicated for multidisciplinary oncology units. So I think it's high time that endometrial cancer management got shifted over to oncology care units and not be done as a single person management. That's actually a big takeaway from the current staging.
Yeah. So as Dr. Anbu put it, it is right that we do refer once we find the case of endometrial cancer. So this is the sort of a case that you may get on your hands when we are operating fibroids. Sometimes an unexpected pathology can land on our laps. But further on, just going on with our case. So she was diagnosed with a very early stage cancer. We did not know the status of the ovaries. But whatever was specimen was removed, it was limited to just the endometrium, more like a foci within the atypical hyperplasia. But post-operative, she had some other issues.
So, ma'am, she presented to us on post-op day 19 with fever, vomiting, abdominal pain, high-grade fever she had. And we started her on antibiotics and we did a CT scan. So,
clinically, what did she have?
UTI.
Ma'am, clinically, she presented with a tender abdomen and fever. So these, and along with some vomiting and pain. So we evaluated.
She had a post-operative urinary tract infection, so we were treating that, but she still developed progressive tenderness and guarding and rigidity. So we did an imaging, and this is the imaging which we did for her. See, fine. It's not playing. Okay, it's okay. Just comment on it.
So, sorry, ma'am, this video is not moving. So
it's okay. Just comment on this.
So the CT scan showed a collection of about 5 into 4 into 6 centimeter size in the right adnexa, which was suggestive of tube-ovarian abscess, and some small collection in the left side of the pelvis as well. So with these findings and the clinical scenario, Smita ma'am, can you tell like what should we plan and what should be the further management plan for this patient? And at the same time,
has fever that's not settling, she definitely needs a laparotomy and washout and draining of the TO abscess.
So yeah, is this expected when you have difficult surgery? Let's say we had a big uterus, we were trying to manipulate. Do you expect these kind of complications in even non-malignant large uteri that you try to remove vaginally? And how, let's list us some of the just the benefit of discussion.
Still quite a
large
rare complication, Anita.
yeah, it's not usually seen, but definitely even a straightforward total abdominal hysterectomy in the best of the hands can have surgical site infection or TO abscess. That's very, very rare though. But if her presentation was classic, she presented on the 19th day with fever, tender abdomen, vomiting. So the clinically, definitely the first suspicion, she is out of that duration when UTI and all presents. And it was a vaginal surgery. So the clinically itself, what we will think first will be a collection. So I mean, I would do an ultrasound first and then proceed. If there was doubt, proceed on to a CT. But in large uteri, when we operate, there can be the long surgery can have some position related pain in the patient, some tenderness, otherwise not TO abscess not seen commonly actually.
Yeah, you're right. So we went on and we planned her for laparotomy because she had an unrelenting fever and this it was a lot of pain for her. But we wanted, before we went, tell you what happened at the surgery. Dr. Sunita, what is your comment that now we have left behind the ovary? There is a malignancy which we have found. So any takes on retaining ovary? She's only 44, well differentiated. Can you tell us any comments on that, please?
Yeah, so when the patient is like it is only 40 per, if it is a non-malignant condition, keeping ovary is not at all issue. We don't remove usually ovaries like when patient is less than 50. She's not having any high risk factor of like developing endometrial cancer or ovarian cancer. So we don't remove the ovary. And particularly when the patient is having like it is a well differentiated cancer, I think localized to endometrium. And sometimes because of the retention ovary, there can be retention ovarian syndrome that can happen. Patient will give rise to some pain and some back pain that can happen. But it is unusual to have a ovarian abscess following this surgery. And maybe patient is very anemic, low in like she was transmitted with 1 unit of blood, and after that she was given iron infusion. And maybe that is maybe the reason patient had abscess, because otherwise a very unusual complication in the NDVH patient is getting a like ovarian abscess.
Yeah, you're right. So we went ahead and posted her for a laparotomy, and at laparotomy, this is what we found.
So we did peritoneal washings with edasialysis, and we removed the ovary. Bilateral salpingo-oophorectomy was done. There was a right tubo-ovarian abscess of about 4 into 5 centimeter size, which was adherent to the right ureter as well as the sigmoid. And there was some right side hydroureteronephrosis as well. Appendix was also inflamed, and the bowel was also adherent. Left side also there was a small abscess. So her post-op period was uneventful.
And here I just want to comment one point. Even if you don't do a oophorectomy for a patient, like this patient was previously not diagnosed to have a malignancy, but you do usually salpingectomy. When you do a hysterectomy to further reduce the chances of ovarian cancer, we routinely do a salpingectomy, though you leave the ovary behind.
Yes,
So patient, but yeah, so opportunistic salpingectomy you do routine practice. Yeah.
Good point, ma'am. Yes, that can be considered. Yeah, so if she didn't have these infections and all that, we would have thought about the ovary because it was only a hyperplasia background with a very, very small focus. But because we went ahead and removed both the ovaries, but we could not proceed with the nodes. So reverting back to Dr. Anbu, now we have this patient who has absolutely low risk. And like as you mentioned, we did do her tumor markers, which we are routinely now doing for everyone. We did her MMR deficiency, the microsatellite instability as we check on IHC by those 4 proteins, and also we did her P53 mutation. These two we are routinely asking for all, and maybe we would leave the message with the audience that we need to do this for all endometrial cancer because this can be done on a routine path basis. It's not a molecular level testing. It's only immunohistochemistry, but it adds on our decision making. So Dr. Anbu, with this background, any comments on adjuvant?
She comes as very low risk. I'm guessing she's a 1A1 now, or because it's minimal myoinvasion is present, right? So she'll probably be a 1A2, less aggressive histology. And we've got one ovary out. We've not staged her, but regardless of this, she'd be kept on follow-up because P53 is wild type. And she is, I guess, microsatellite stable. The other way of doing it would actually have been whole mutation testing, but I'm guessing that's not being done because of the cost. So this particular patient, I would just keep her on follow-up.
Okay. Thanks for those inputs, and that's what we are trying to do for her, and we'll keep her on. So I'm just coming back to what lessons did we learn. So as we started saying, like Dr. Sneha was saying, we probably have to do endometrial biopsy for all those who we anticipate where we are morcellating. That would be a safer thing to do. And we may come across unexpected, in spite of our, sometimes can have a normal biopsy, as we'll see in the following cases, still can have malignancy that comes as a surprise. So it's good to do a preoperative pipel biopsy and then go ahead for the morcellation with all the precautions that we discussed. Anybody else would like to contribute? We'll be going on to the next.
Yeah, so I just wanted to tell, because though the guidelines says age more than 45 year, ET more than 12 millimeter, you should go for endometrial biopsy. Nowadays, as we discuss, cancer is not confined to only a perimenopausal or a postmenopausal age. So I think any patient having a heavy menstrual bleeding when ET is thick or any irregularity in the ultrasound, always you should go for endometrial pipal biopsy and a pap smear. So pap smear and endometrial pipal biopsy, these two are mandatory when you are going for any hysterectomy, particularly patient when she is having abnormal uterine bleeding, means heavy menstrual bleeding.
Excuse me, I'm Dr. Gundish, ma'am. I'm Dr. Gundish. I've been introduced as Dr. Jagjit, so there is a lot of confusion which panel chairperson I was. Anyway, ma'am, I just wanted to thank Dr. Jeremy for such a wonderful webinar. Just 2 points from this discussion. Like Dr. Anubha said that these patients should be shifted to onco centers because of change in the staging. Madam, it is not practically possible because there are not so many onco centers. But I do agree that all gynecologists, if they are working in or operating on an onco case, they should consult with onco specialists so that at least patients are given best possible treatment. And second, madam, salpingectomy in this case. Vaginal hysterectomy normally we do not do complete salpingectomies.
Yes.
The abdominal we do, in laparoscopic we'll do. But in case of vaginal, we are not usually able to do. But yes, if we are in ultrasound, we find that if there is any ovarian tumor or anything, then in the vaginal hysterectomy also we can remove those adenoxa. But unless suspected in TVS, we are not doing salpingectomies. That's all, ma'am.
Sure, sir. Thanks for your comments, sir.
But in this case, madam, actually you've said the P53 is positive. So, I mean, like, I didn't get that weakly positive or positive, because P53, once it is there, then it means it's just upstates your disease. It goes up to, like, I think, like 1C or 2C. So, like, usually what I mean, like, when we work with the team, they usually suggest the patient for radiation along with chemotherapy whenever the P53 turns positive. But I didn't get the term of weakly positive, because here they give us whether positive or negative only. We have not seen the report as weekly, so I didn't know whether to comment on that, whether is it significant or not.
You're right. P53 has significance, but when we say it's mutant, it has to be either fully positive or there's a way of reporting it. This wild type positive is not equivalent to being positive. It's like almost considering it negative, ma'am.
Okay, got it.
That's why it's being considered as low risk. Right?
So once they're already diagnosed to be malignant, they're always with the oncosurgeon. But most of the time, we are caught unaware, thinking that it's a fibroid and an adenomyoma, and we land up with a diagnosis post-operatively. That is when we call the team of oncosurgeon and the medical oncologist into play, and they also come into the role. Most of the time in these sort of cases, when they've already completed the family and you have a report, we do discuss with the patient about the option of going back and doing a completion of removing the ovaries and the nodes too. And if the patients opt for it, having done that, the concept is the disease is totally cleared out. So that could also be given as an option. In this particular case, she landed up on the day 19, so you were forced to go in for other reasons. If not, when you have a histopathology report in the first week, you can always call them, counsel them. The second time, you could still go in with a laparoscope and do the completion.
A good point brought forward. That's what we do.
What we usually do, I think at the end of the surgery, even for all benign surgeries, age above 40 or any other risk factors, we should do an endometrial biopsy. Like most of the time, we can do it at the first visit when the patient is coming also, and also at the end of the surgery, cut open the specimen and see if there is any suspicious looking areas. And if it is well within the time, we can also always send for a frozen as well and take oncology help if required.
Sure. Nice points brought forward. Completion surgery is a more certain option when we have a unprepared malignancy of a surgery. That's how we take it forward, ma'am. Thanks for your inputs. So going on to a second case, this is a 55-year-old lady with postmenopausal bleeding. She was presented with postmenopausal bleeding and was evaluated for the same. No significant findings other than she was BMI of 33.1. And yeah, Dr. Priya, for any further investigations and workup plan for her, please.
So, I mean, I didn't get the examination findings about.
Specific,
yes, the
uterus
uterus normal size, but anyway, like, now we feel that the transvaginal scan is another obstetric finger. So definitely we will go with the TIS, TVS. I don't think anybody is going to leave without a TVS. So we all have it in the OPD. So we definitely go ahead and do it, madam.
Yeah, ma'am. So we did a transvaginal scan and we had endometrial thickness of 14 mm with small cystic spaces and uterus was normal size. So as you said rightly, we also went ahead and did a biopsy, came as negative. And because there was a suspicion of a polyp, we also wanted to do a hysteroscopy because it was looking like a smooth polyp and the biopsy was negative. So that was the plan.
Yes.
So, Dr. Renju, do you agree with this plan or any changes in the approach?
Yes, ma'am. The ultrasound, it seems to be a polyp, no irregularity also, and all the margins are well defined. The borders are very clear. So hysteroscopic resection is ideal, actually.
So you would plan for a hysteroscopic resection because it's a benign pathology.
Yes,
That's
but still I'll be on guard because she is obese, a hypertensive diabetic. She has everything that points that there might be increased estrogen production, postmenopausal lady and all. So I'll be on guard, but still I'll opt for hysteroscopic resection only, ma'am.
Anyone for a hysterectomy in a group? This is the first step.
Actually, she is 6 months.
So she has 6 months duration. She is a perfect recipe for CA with BMI and almost ongoing bleeding for 6 months. And I would also want to know whether that polyp looked absolutely plain, no vessels on it, or it was a vascular polyp.
Yeah,
And
the
if you
color
could
Doppler findings are not given in that. And if you have a 3D TVS, we can also see the polyp. I mean, but that's very, very misleading, madam. Many times polypoidal endometrium also appears as polyp. So the 3D, I don't think that has much role.
So I think this case we should go, madam. This case, matlab, like endometrial people biopsy were done first, then it was planned for hysteroscopy. Yeah. But when we are seeing a ET up like 14 millimeter to cystic spaces and a postmenopausal bleeding, I think the ideal is always to go for a directly hysteroscopic guided polypectomy or biopsy. That is the ideal one.
So that is what exactly I wanted to say, that hysteroscopic directed biopsy should be the best, where you can go for that polypectomy along with the guided biopsy. That you can visualize the entire cavity. I think that should have been the better plan. And yes, hysterectomy, as you said, I think we have to individualize the choice and the choice of the patient as well as the surgeon also here. Postmenopausal bleeding, 55 year, right? So whether she will be coming to you for follow-up regularly, whether she's an educated lady, and whether she'll be reporting to you what is the current histopathology findings and how frequently she needs the follow-up. I think everything has to be taken into consideration. Otherwise, if you feel that she's uneducated and from a lower socioeconomic status, so I think best way is to go ahead for hysterectomy.
Well said. And also, if she is coming from far away and has come for a one sitting with the gynecologist, I think definitive surgery will be better, especially where she has so many risk factors.
And importantly, I think I would stress on the fact we have to take a good family history. And if there's any family history of other malignancies related like breast or in the family, then it puts her at a higher risk. So we'll put everything together, and maybe some of us would want to do a hysterectomy at the
only problem with doing a hysterectomy without knowing the pathology is, no, madam, whenever in postmenopausal bleeding, if you have done just a simple hysterectomy and it turns out to be an endometrial CA, you're forced to go back inside and complete the staging. And suppose if we say that, okay, I will do staging for everybody, then you're doing lymph node dissection for something which is not needed. Either you overcorrect or undercorrect. So I think, like we should look it forward to take it as a office hysteroscopy so that you see, and if you really have a doubt that yes, it is malignancy, then you proceed like with, because nowadays we are living in the world of litigation. Just thinking that it's good for my patient, she's not going to come back to me, let me do the hysterectomy, and you do a half and half surgery and you are going to go and give a compensation of 1 to 2 crores. I don't think it's going to be useful in our level. I think so, madam.
And when complication happens, the same patient will give back to you. You know better than us. You should have gone for a biopsy instead of going. I think we should give the option to the
I
patient.
think
If
never can we afford to overlook the steps of diagnosis.
Yeah,
It is always
exactly.
imaging followed by tissue diagnosis and then discussing with the patient on what to do.
Exactly.
And everything should be
Hysterectomy is
documented.
also,
Yes.
hysterectomy is a choice after the histopathology. Okay,
Yes.
so directed biopsy followed by the decision of definitive surgery.
So when we do the directed biopsy with the polypectomy, we need to tell the patient this may not be the complete surgery. And if at all something turns positive, we may be calling her for a hysterectomy again. Is the message. We should get it across very clearly into her mind.
Because we agree with the question, madam. Every time when a patient comes to the OPD, she always says, anyway, you're going to give a biopsy. After that, you're anyway asking me to come for a surgery. Why do you want to do the biopsy is what the patient asks.
Yes, exactly.
We have to be very clear that without knowing it's benign or malignant, we are not doing justice for you. So you have to go for a diagnosis and then proceed with surgery.
I think that is where the role of the office hysteroscopy really comes in, because the
Yes.
patient need not be exposed to twice anesthesia and the entire spectrum. If you can do a thinner scope and do an office hysteroscope and do a guided biopsy then and there in the office, it becomes a boon to the patient.
If I tell you my experience, what we do is we are not considering hysteroscopy as a surgery, but we have been telling the patient and what the consent is, it's a type of examination, testing, it's a type of investigation, it's a diagnostic hysteroscopy. Though we are going for biopsy, it is still a diagnostic. We're just removing the polyp and sending it for histopathological examination. So I think it's better that you tell the patient that it is a type of investigation which will further clarify what exactly is your diagnosis.
It's an extended spectrum of the investigation to confirm the correct diagnosis.
Yes, ma'am. So we agree with all the points put forward. So we did actually plan for a hysteroscopic resection for her. And that hysteroscopy, the finding was that it was a more vascular polyp and started having bleeding, in which reason they had to convert. And with the polyp resection was scored by the step W scoring. So I asked Dr. Mapita to please let us know what the scoring is, and are we still using it, because this was introduced in some time back. So just what does the rest of the panelists feel also, you can tell.
Ma'am, if I may interfere here, this is only for myomas, ma'am. This is not for polyps.
Yes, polyp.
This is for
Yes, ma'am.
myomas to decide the feasibility of whether one needs to do a hysteroscopic removal of the myoma or a laparoscopic removal. Only for that classification, or to categorize the patient into hysteroscopy and laparoscopy, we do this. Otherwise, the step W classification is not for a polyp. It's only for submucosal myomas.
Yes, I agree with you, but just put it here for completion, because this is a case which I borrowed from my colleagues and they had documented these findings. So,
Okay, ma'am.
Mapita, any comments on that?
Yeah. Ma'am, before knowing the scoring system, basically we need to know the characteristics of the polyp when we were doing the hysteroscopy, office hysteroscopy, whether it's a sessile polyp, single or multiple polyps, whether it's in vascularity is there or not, where it is arising from. And depends on that, we can make out whether it's a benign or malignancy. Like ma'am said, it is only for myomas. But it's a multiple polyps. Basically, they would have been scored this. For a myoma, we will be like 0, 1, and 2. It is if it is fully inside the cavity, it is 1. And more than 50% inside the cavity, it's fully inside 0, more than 50% is 1, and less than 50% is 2. So like step W classification depends on the base of the where it is arising from, where it is attached to the lateral wall or not, penetration is there or not, and depends on the size we can score. The scoring is 0 to 4 and 4 to 6 and 7 to 9. If it is only the low score is 0 to 4 and all, we can do one single hysteroscopic polypectomy, which is low complex surgical procedure. And if it is score is 4 to 6, we have to do a 2-step procedure. Either we can give GNRH and do this 2-step procedure, or without an GNRH, we can do 2-step procedure. If it is score is more, we have to think about other things than an hysteroscopy like laparoscopy, whatnot.
Sorry to interrupt. Are we talking about a postmenopausal lady who's come with a polyp where we are planning to give a GNRH to reduce the polyp and then go for a 2-step procedure?
No, that
It's
is
not at all
exactly
applicable
only for
for this
myomas and
patient.
not this patient. If you
So
have a
just
large myoma, instead of doing a 2-step, you could shrink the myoma and then do it.
it's
Not
not for
pertinent
this.
to this
Not for
patient.
this patient. Not for this
Just
patient.
the score. That's all. So coming back to our case, we did convert to we kind of had to put on the hysteroscopy proceed, and we went on to do a hysterectomy. Again, she also had a non-distant vaginal hysterectomy. And unfortunately for her, even though the preoperative biopsy was negative, the postoperative biopsy came back as foci of well-differentiated endometrioid carcinoma. Because it was patchy, we could not comment on the tumor size, and this was staged as stage 1A2. And if you remember from the staging we shared, it's very early stage. Here we have removed the ovaries, and we also did the tumor markers. It was a ER-PR positive tumor, which means it's a good type of tumor. Again, she is P53 wild type, and MMR was negative, which is all good factors. So we were lucky. So coming back to you, Dr. Anbu, this time we have a little bit better. We've not contaminated anything. We've not morcellated. We've just removed the uterus through vagina. Any other details you will need, and any role for adjuvant in her, and what is her prognosis, please?
Obviously, she's still unstaged, right? Because you can't go by the Mayo criteria of less than 2 centimeters, less than 50% anymore. And the recommendation is that all cancers need to be staged. So ideally, she would have to have had a sentinel node mapping if facilities are available. And if not, then the usual thing is to do a pelvic lymph node resection. So if you look at the European guidelines, this patient will be considered as a unstaged CA endometrium 1A2. This is a presumptive diagnosis because about 3 to 5% of patients, even if they are endometrium confined, once they are myoinvasive, they can have nodal mets, and those are the ones we want to pick. Now, the point where molecular classification is scoring is we go back home thinking we've cured her, right? Because we've got uterus out and it's all intact, we've got the ovaries out. But we do see these kind of patients coming back with recurrences, and oncology teams see that more often. And that is the reason why I think molecular staging may have a good role to play to basically solve the puzzle. Why are these early cancers, so-called good prognosis cancers, coming back with recurrences, maybe even at 5 years? I've seen patients come back at 5 years with lung mets, and there's no explanation why. So this is still unstaged, but having said that, it's very early. So we would have given a patient the option of either observation, close surveillance, or maybe go one stage up and do a vault brachytherapy as per guidelines, because guidelines would suggest that. But I would consider this good prognosis disease. Yes.
Good. Thank you.
Can I ask a question here, Dr. Ambu? So can you, this patient, when it's early stage endometrial cancer, as you said, we can go for a P53 or the pole mutation. And based on that, we can, if patient is affordable, we can give, or just follow up we can do.
Pole mutation is positive. It's very good prognosis. Almost 100% of patients, even with more extensive disease, are not shown to have recurrences. And if they do have recurrences, they have very good prognosis. Therefore, in a stage 1 or 2, regardless of what the substaging is, if pole mutation is positive, patients get downstage to a 1A. And the reverse is true for P53 mutation positive, where if more than 90% of the cells stain for P53 stain, then regardless of whether they are 1A1 or 1A2 or 1A3, they will get upstage to a 2C, which automatically qualifies them for radiation therapy plus or minus chemotherapy. But most units are giving chemotherapy based on the current recommendations. So if we do molecular staging and if we have good prognosis disease, then we know exactly what to do. So the ideal thing, I understand we are living in a country of vast disparities, but the ideal thing to do is to stage and to also do molecular markers wherever it's possible. But if not, we're still relying on histopathological parameters, which is what we've done in the current case, right? We've still looked at her parameters. It's a well-differentiated disease, very minimally myoinvasive. She's not P53 positive, which is the most obnoxious group among these patients, and therefore we are okay to follow up this patient.
Yes. Thank you all for your inputs. And Rani ma'am, is it too late? Should we wind up? Because I had one case of infertility. Would I have 5-10 minutes or should we stop?
Another 5 minutes, not a problem, ma'am.
So then
I mean,
go to
Sana or I think Priya, we have time, no? Another 5-10 minutes, we can go ahead.
Okay, quickly, I'll just take us through another very patient load, which we have fertility patients who come to us for fertility treatment and are diagnosed with endometrial cancer. I think we all face the dilemma as specialists. They come and they have an endometrial biopsy and they have well-differentiated endometrioid adenocarcinoma, and then you're stuck. You want to retrieve their eggs, you want to implant, and you're all ready, and then we are kind of put a hold. So I'm going to just fast track this. I'll just finish. We all know that there are a various spectrum of treatments, but high doses of progesterone or medroxyprogesterone with or without a levonorgestrel intrauterine device, plus weight management and lifestyle modification. This is generally the way we approach a patient. So here's one case, just this I will discuss and we can probably call it a day. So this was a patient who's a normal BMI, and she came to us with this initial finding on a hysteroscopy of a growth within the endometrial cavity, basically evaluated for a thickened endometrium. It showed polypoid endometrium, and that biopsy came as well-differentiated adenocarcinoma. The image here shows we always, for planning conservative management, we plan for MRI to stage the disease and to know if it's only an endometrial limited disease. And this is what was pre-op, and this is after treatment, after 3 months. And then following the treatment of 6 months, she had still a thickened endometrium, but her biopsy, doing the 3 monthly biopsies, we got a negative biopsy after progesterone. And as you see in the last part of the screen, we made her to have an undergo withdrawal bleeding, and then the endometrium became normal. And then we were ready now to start her treatment. So I've fast-tracked the first part. So Dr. Priya, now you have a patient who we have treated and given back to you with a negative endometrial biopsy. So where do we take this? How do we take this forward?
I mean, we just have to make the patient conceive early, but it doesn't mean that she has to conceive in the next month. So you just give her a short duration to try for natural conception, say somewhere between 3 to 6 months. So just weight reduction, because the BMI is somewhere around 38. So that itself for a like PCOS patient, that will help her to ovulate. Maybe a little bit of ovulation induction drugs, and like if the male factor is fine, then we can give it for natural conception. If it is not working out, then we will start off advising them for an IVF, to just go directly, because we cannot waste more time, because many of these patients, they'll come back with with recurrences. Though they come, they have a little bit of resorption. We say that okay, they have normalized, but we all know that anytime they can come back and have a adenocarcinoma anytime.
Sure. So yeah, we agree with you that these patients have to be fast tracked. So going on to do what kind of fast tracking, as you said, you can allow them to wait for a short while, but they have to be under close surveillance, and preferably we should ask the help of a fertility specialist to fast track the thing. So basically a team effort of all of us, and genetic specialists also come into play, because a lot of genetic mutations are related to early onset endometrial cancer like Lynch syndrome. And if we do have a mutation, she warrants even a pre-implantation genetic diagnosis before putting in the embryo. And of course, we need to keep in mind the maternal fetal people because they already have comorbidities, the patient's family, and most certainly the oncological team, because we need to have a plan after this also. So conceiving is one part, treating is one part, and then after the treatment, how do we follow up and what? Maybe we'll ask two of our panelists to take the comment, and then we'll stop Dr. Sunita and then followed by Dr. Anbu.
Yeah. So follow protocol, particularly when this like during the fertility sparing treatment, you have to see the patient as Priya told, they should conceive as early as possible, and either it is natural or you do a IVF. And when the patient is having, when you do a like biopsy, and there are some contraindications also where you cannot give the fertility like means conservative management. Suppose that is a biometal invasion or it is an aggressive variety of endometrial cancer, and those things you have to first confirm, then you can give the patient a conservative management, and following that you can go for a fertility. And once the fertility is over, again we have to follow up the patient, we have to do a re-biopsy and see if needed, that time we can go for a complete surgery.
Dr. Anbu, any comments on so far?
So the role of completion surgery as such, it used to be the rule, but now we are starting to think of endometrial cancer more like a chronic disease management, where potentially we could have complete reversal of endometrial cancer by high-dose progesterone, allow her to have a baby, and then provided she is okay for active surveillance, which is continuing progesterone during her interpregnancy gap and still agreeing for close clinical follow-up, it is now okay to have patients be on follow-up. So it is no longer the rule that we need to remove these uteruses. We can allow them to have maybe more than one pregnancy, but this needs to be a bilateral decision, provided the patient is, okay to understand the consequences, because this is a cancer. So potentially there can be recurrences elsewhere, but there is an option of continuing just close surveillance and possible future pregnancies.
I would just like to add upon saying that to any fertility sparing conservative treatment, we need to keep the patient informed that this is not the best mode to deal with her. And this is just tailor-made for her for the situation of conserving fertility. And this
Very
needs to be informed to her.
Yes.
In fact, documented because
I rushed you through the last case. I wanted to actually deliberate on it along and a whole host of you who are doing fertility, and it would have been interesting. I'm very sorry I had to rush through that. Thank you, Dr. Jayarani, for this wonderful opportunity and my good panel who I enjoyed interacting with. And all the
Thank you,
people
madam.
Thank you, ma'am.
It was such a lovely panel. We had a really good discussion.
Thank you.
Thank you, ma'am.
Thank you, ma'am.
Thank you.
Thank you, sir, for being as
Thank
chair.
you, ma'am.
Yeah.
Thank you, Anita ma'am. Thank you, Jairani ma'am.
Thank you. Thank you, ma'am. Thank you so much.
Madam Jairani madam finally came.
No, I'm here. Yeah, you can
Jairani
say
madam
that.
has been here.
No, I'm all
Jairani
time
madam first
here.
I joined first.
Yeah, you're always welcome. You're always my smartest easy. Thank you.
Thank you, ma'am.
Thank you so much.
Thank you, ma'am.
On
Good
behalf
night
of
to all.
FOGSI, No to Work Committee, as well as the FOGSI Oncology Committee, and our Federation, Tamil Nadu Obstetric Gynec Society of Southern India, it gives me great pleasure and honor to thank you one and all for your wonderful presence here to make this webinar a grand success. A very special gratitude and thanks to our President, Dr. Sunita Madam, who has been gracefully inaugurated our webinar with a great inspiration, and Ramani Madam for her very encouraging and very uplifting talk, and all the support from the Federation, Sampath, and my society President Vijaya, and all the committee chairpersons, especially dynamic Dr. Kiran and Dr. Sharita, Madam, all were very much supportive to make this webinar a grand success. And a very, very special thanks to my elite and very knowledgeable and a very, very senior speakers, Dr. Bose sir, Dr. Raja, and Dr. Anita Madam, for your wonderful presence to make this a very knowledge-packed and a well-informed webinar. And a very special thanks to all the very energetic and a very smart panelist, Dr. Priya, Dr. Sunita, Dr. Anbu, Dr. Renju, and Dr. Vanita, and Dr. Gunnar Singh, sir, and the very special experts, Dr. Sneha. We are always a knowledge-packed one with so much of great knowledge sharing, and Dr. Vanita, madam, for all their expertise, and a very special thanks to the CMC Velo team, Dr. Smita and Dr. Pratima, for their wonderful presence here. And special thanks to the chairpersons, whoever, who are very much kind enough to join us, Dr. Neeru Thakkar and Dr. Aarti Karnal, sir, Dr. Jagdish Singh, sir, Dr. Sangeet Palwa, madam, Dr. Madhu Nakbai, madam, Dr. Manush Singla, madam, Dr. Gurneesh Singh, sir, and Dr. Manju Sinha, Dr. Gini Gupta, madam, and all the delegates here for your wonderful presence. And thank you so much for making this webinar a grand success. And we really thank all the oncologist team for your wonderful sharing your knowledge and expertise to all our gynecologists to treat and have a good knowledge of for treating their patients. Thank you so much. And a very special thanks for all. And a special thanks to Sri Priya, who has been very helpful, Sri Events, for helping me to organize it, and the MKO team for sharing me this platform, Dr. Sana and Rajeshwari, for making this, this platform in a very good way. And thank you one and all for your kind presence. Thank you. Thank you so much.
Ma'am. Thanks, dear, and best wishes to you for your elections. And just utilize this opportunity to, humbly seek all of your blessings, support, and votes for my candidature as FOGSI Vice President for the upcoming elections. Thank you so much.
And a special thanks, Dr. Sneha, madam, for being so dynamic. And I really request all the chairpersons and all the presidents here to support me for the candidature for the No to Violence Against Women Committee, which is very passionate and close to my heart. Thank you. Thank you so much.
Thank you so much. Thank you. Bye. Thank you, Dr. Gurnesh.
Recording stopped.